good morning or early afternoon, depending on your coast of residence. My name is Dr. Michelle Albert, and I'm honored to serve as the president of the Association of Black Cardiologists, or ABC. Thank you for joining our COVID-19 webinar, Generating Heartfelt Horizons, COVID-19 Prevention, Myths and Realities, organized by our COVID-19 Task Force, which was formed at the beginning of the pandemic here in the United States in March of 2020. This webinar builds on our impactful webinar series about COVID. Indeed, our very first webinar, our first COVID webinar was one of the very first COVID webinars about health disparities and health equity related to the pandemic and its disproportionate impact on Black, Hispanic, and Native American populations. Just as we have in our previous webinars, we are committed to bringing you the latest information about COVID informed by science and our best available knowledge at this juncture in time. We mourn the passing of at least 400,000 Americans, with 1 in every 700 Black persons having COVID or dying from COVID. As an American, I join you today with renewed hope as a Black woman in a country who just saw the inauguration of President Biden and Kamala Harris, the first woman of Black and South Indian descent elected as Vice President of the United States. Additionally, science has delivered with rapid creation of a COVID-19 vaccine, which gives us hope for all of our futures. Therefore, it is with great honor that within this context, ABC brings to you trusted voices who use the principles of science and public health to talk about the COVID vaccine, the urgency for our communities to get the vaccine, vaccine hesitancy, and ongoing innovative work from our from our ABC members. This webinar will tackle health equity pertaining to COVID-19 and vaccination. Also, we dedicate this webinar to Dr. Julian Haywood, one of our ABC founding members, who passed at the ripe age of 93 years old on December 24th, 2020. Dr. Haywood was a professor emeritus of medicine at the University of Southern California. He was honored clinical professor of medicine at Loma Linda University. And as you already heard me say, he was a founding member of the ABC, the coronary care unit at the Los Angeles County Hospital at University of Southern California Medical Center, which was established in 1966, was renamed the L. Julian Haywood Coronary Care Unit in 2016. I had the privilege of actually visiting this coronary care unit early in 2020 when I served as a visiting Julian Haywood professor at USC. That was the last time I saw Dr. Haywood. Participated with him in rounds, participated with him at the lecture that I delivered, and followed by clinical lecture and a walk through the ICU. He was also among the first Black physicians to be appointed a professor of medicine at a non-minority institution in the United States. Dr. Haywood is a soft-spoken giant who helped usher in successive generations of African-American cardiologists and other physicians. Dr. Haywood, we will continue to honor you. We dedicate this webinar to you and your family. The ABC misses you dearly. Rest in peace. So, as we launch into this webinar about vaccinations, one of the most important things is to know that we, the ABC, support vaccinations. Here you see a collage of our ABC leaders who are proud to display that they've been vaccinated. We have such members as Dr. Joe Hargrove, Dr. Malcolm Taylor, myself, Dr. Lisa Cooper, Dr. Hargrove again, Dr. Keith Ferdinand, Dr. LaPrincess Brewer, Dr. Gwen Taylor, Dr. Richard Allen Williams, our founder, Dr. Tracy Paul, our own Dr. Elizabeth Afili, our board of directors chair and former president of the ABC, Dr. Ogunwumi Modeli, Dr. Modeli, I'll call her Dr. Modeli, Dr. Joseph Poku, Dr. Barbara Hutchinson. We are all getting the vaccines, and we urge you to get them as well. Our second webinar, the paper from our second webinar highlighted several facts, which are also prominent as it relates to the vaccine. At the time, we had this diagram in a paper published in Nature Cardiology Reviews focusing on COVID-19 testing challenges. Here I've inserted COVID-19 testing and vaccine challenges because indeed what you'll hear today are these same challenges that pertain to COVID-19, accessibility, as well as hesitancy. Today in this webinar, we continue to honor and say congratulations to our COVID-19 Innovation Award winners. Today we'll have our first 3 presentations from our COVID Award winners, including Dr. Mrna Morris, who's an assistant professor at Emory University in Atlanta, Georgia. Dr. Dapo Ilyumade, who's a chief fellow in cardiology at University of Miami, and Dr. Donald Lynch, who's an assistant professor of medicine and cardiology at the University of Pittsburgh. So we want to welcome our award winners and really look forward to their presentations. So as we think through this webinar today, it created this outline of our webinar. We are honored, and I will shortly introduce Dr. Marcella Nunez-Smith, who is the chair of President Biden's COVID-19 Health Equity Task Force, who will be making remarks on our webinar today. That will be followed by Dr. Peter Chin Hong, who will talk about COVID-19 vaccines in communities of color, suspicions and solutions, followed by Dapo Ilyumade, who will, along with 4 medical students from FIU, talk about youth tracking COVID-19, a partnership between South Florida medical schools to slow the COVID-19 pandemic by addressing the infodemic. Dr. Mrna Morris will focus on the Georgia COVID-19 Consortium Academic Clinical Community Partnership to study COVID-19 impact. And Dr. Donald Lynch will focus on leveraging mHealth to mitigate COVID-19's impact in African American communities. So without further ado, I would like to introduce Dr. Marcella Nunez-Smith. Dr. Nunez-Smith is an associate professor of medicine and public health and management at Yale School of Medicine. She's also the associate dean of health equity research at the Yale School of Medicine. She was recently appointed as the chair, and today is the first day actually in this position, as the chair of President Biden's and Kamala Harris's COVID-19 Health Equity Task Force, responsible for determining helping to roll out or leading the rollout of the COVID-19 response from the Biden-Harris administration. Previous to that, she served as co-chair of the Biden-Harris Transition COVID-19 Advisory Board and on the community committee and was community committee chair for the Reopen Connecticut Advisory Group on behalf of the Connecticut Governor Lamont. Dr. Marcella Smith is a distinguished physician in her own right. She's board certified in internal medicine, and she's a principal investigator on several NIH and foundation grants. Welcome, and thank you for participating in our webinar, Dr. Marcella Nunez-Smith.
Good morning, everyone. Thank you so much, Dr. Albert, for that kind introduction and for all you and ABC are doing to advance equity during the pandemic. The leadership of professional organizations is just critical for the work we have ahead. Focusing on COVID-19 prevention myths and realities is a fitting theme for the conversation the group will have today. So I appreciate this opportunity to spend a few minutes just outlining the administration's plan to ensure equity in the COVID-19 response. We think it is essential we disseminate our plan, but also that we listen with humility to those with the expertise, such as here today, and lived experience to ensure that we get this right. This is fiercely urgent work. We see concerning acceleration in the numbers of folks who are personally affected. Quite frankly, of lives lost. Very tragically, we're projecting the possibility of 500,000 deaths in the US by the end of February. And the impact on communities of color has been particularly devastating on both economic and health fronts. To date, it's 1 in every 735 Black Americans who has died of COVID-19. And you've heard me say this before, this is a grief gap, it persists, and it reflects the underlying inequities across, quite frankly, all of our societal systems, whether we talk about the economy or housing, food, or our criminal justice system. And we're learning more and more every day about how the symptoms of COVID-19 can persist in this syndromic way that can be debilitating. And racial ethnic disparities are emerging there as well, as this group I know is very familiar with. So all of the science, all of the evidence, all of the data says we must do everything to prevent COVID-19 infection in the first place. We must vaccinate an entire country. So simply put, we know we need more people eligible for vaccination sooner. We need more places for people to get vaccinated. And of course, we need more vaccines. That is our path to get to the other side of the pandemic and to a new normal. So last week, the president laid out his 5-point COVID-19 vaccination strategy about getting more people vaccinated and creating these vaccination sites, including partnerships with community health centers and community-based organizations and trusted providers, working with local pharmacies and using mobile vaccination centers when needed. We have to increase supply and get it out of the door as quickly as possible. And definitely we'll need to mobilize more personnel to get shots in arms. And fifth, really ensuring that everyone has the information and confidence they need to get vaccinated. And we all know that equity does not happen by default. We're already seeing that African Americans are less likely to get vaccinated than European Americans. This is among the top priority group of healthcare workers. So, why do we see that? It's the result of challenges such as access, also some mistrust. And we know we're likely to see similar concerns across the broader population. We have to prioritize getting healthcare workers the information they need to feel confident in vaccination. And that when they're ready to say yes, structural barriers don't stand in the way. President Biden and the incoming administration, we are all committed to rebuilding trust and to being intentional about getting to equity. An executive order today will establish the COVID-19 Health Equity Task Force, and I'm honored to serve as chair. The task force will convene national experts and will provide specific recommendations to the president for allocating resources and funding in communities with inequities and COVID-19 outcomes by race, ethnicity, geography, disability, and really other considerations as well. What else will we do? The federal government is going to extend equity data collection and reporting as a foundational component of our work. We have to use data to drive action. We will ensure equitable access to PPE, testing, treatments, and vaccines in medically underserved communities and in high-risk settings, including assessing and updating pandemic response plans to ensure equity. We will expand access to high-quality healthcare and will bolster the community-based workforce. We will work to strengthen the social safety net to address unmet basic needs such as food and housing for those individuals and families affected by COVID-19. We will consider the unique needs for some of the groups at the greatest risk, such as the homeless, the incarcerated, those living with disability, and those living at the margins of our economy. So in closing, I want to be clear. This is a national emergency. We absolutely need to treat it like one. We are in a race against time, and we cannot accomplish this critical work without help from you. Your work will ensure justice and equity. So thank you to ABC for leading. The commitment of this group is commendable. We look forward to working with all of you on this journey to equity. And moving forward, we want open lines of communication. We want to hear when we're getting it wrong and ask for your patience when we face those expected stumbles. We want to be held accountable. So thank you again, and here's to a great meeting.
Thank you, Dr. Nunes-Smith, for terrific remarks. We'll turn to now Dr. Peter Chin-Hong.
Thank you, Dr. Albert. It's my pleasure to follow that amazing presentation with primer on vaccination, specifically targeted to communities of color. So what I'm going to do today is to do three things: talk about the science, specifically speaking about the epidemiology of vaccine distribution and uptake, vaccines 101, going through a little bit of science, and touch upon two current issues in vaccinations in particular. I'll then turn my attention briefly to suspicions and then to solutions. So what do we know about the epidemiology of vaccine administration in the US? To put it short, it's kind of a mess, actually. And there's been a lot of expectations that haven't been met. On the left side, you can see that, we're looking, this is very current data, as up to date as yesterday, per 100 doses administered by state. And you can see that California is at 3.9, sort of trailing many of the states. And surprisingly, some of the more conservative states where mask wearing wasn't upheld, like North Dakota and some parts of Florida, are doing a lot better than California. Part of the problem is California is so populous and has so many multiple systems of healthcare, and that it's very, very difficult to really implement that well-oiled machine that we were hoping for. But hopefully, as evidenced by Dr. Nunez's talk, we will get better. When you see the percentage of the supply used, again, huge disparities in the country, with North Dakota using about 81% of their supplies, California 37%, Florida 49%, and New York 56%. So you can see by the shading of green where people land in that respect. We can see that this is a global phenomenon of inequities, and we complain a lot in the United States, but per 100 people in the population, we're not doing that badly. You can see we're sort of like green here compared to Argentina, 0.5, Guinea, 0.004, the only African country to start vaccinations. India 0.05, and even China, a powerhouse of vaccine development, only 1 per 100. Israel, of course, is the beacon of a well-oiled distribution system in the world, with 33 per 100 vaccinated as of yesterday. So let's give a little primer on vaccines, just so that we all are on the same page. So the two main types of vaccines you'll be hearing about upcoming, of course, we all know about the mRNA vaccines, and you'll be hearing a lot more about the adenovirus vector vaccines soon, specifically the Johnson & Johnson vaccines, which I'm very hopeful about. How do they work? Well, they both do the same thing, which is to present a message for the spike protein on the coronavirus. It's not alive, and then the body develops neutralizing antibodies towards these spike proteins. And then when a real COVID comes along, these neutralizing antibodies will stop it in its tracks. The mRNA vaccine is interesting because it's just really this tiny piece of RNA, which is super fragile. You encase it in this fatty bubble. And it's thought that this fatty bubble is responsible for some of the severe allergic reactions that we're seeing, which is interesting because as we see the other vaccines come up, many of them are adenovirus vectors. I would predict that you wouldn't see any of these severe allergic type reactions, mainly because they don't have that polyethylene glycol fatty encasing, which is suspected to be, again, the progenitor of some of these severe allergic reactions, anaphylactic shock, etc. How does the adenovirus vector vaccines work? Well, the end product is the same thing. Again, you're making these spike proteins, but it's using a virus, a killed virus or an inactivated virus, which causes a common cold. And virus acts like a spaceship to bring this message into the cell. In both cases, the cell becomes a factory for making tons of these spike proteins, but with no live virus, and you develop antibodies against them. So where are we in the race against vaccines? 4 vaccines. We have Pfizer and Moderna. They're both mRNA. AstraZeneca, we'll talk a little bit about Johnson & Johnson, and the Russian vaccine. They're all adenovirus vectors. Novavax, trailing Johnson & Johnson, but you'll be hearing about that later in the year for sure. it's essentially a protein vaccine made up of these little spike proteins that are assembled on these cells outside the body, and then these little nanoparticles are then injected in the body. Again, the idea is to show the body these spike proteins, no matter how you do it, and you develop antibodies against it. The Chinese vaccines are the only ones that are sort of most traditional, where they're using actually virus itself that has been inactivated. And their results in the vaccine trials have been disappointed. Largely people speculated because it doesn't make such an immunogenic insult to the body. So what's the data so far? Well, everyone knows about the Fisa vaccine, where you can see an overall 95% efficacy 7 days after the second dose in a very large study. The results in subpopulations of Black and Latinx population look very promising in these phase 3 studies. When you look to see what the vaccine efficacy after the first dose is, you can see that the curves really start to separate after around day 10, day 7 to day 10. And this is a rationale for why the UK has come up with their idea of vaccinate everyone as soon as possible with just one dose and figure out what to do with the second dose afterwards. What about the Moderna data? Very similar to the Pfizer data. You can see about 94% efficacy, 14 days this time after the second dose, slightly smaller study. And African Americans and Latinx are combined in this analysis, 97.5% efficacy. The age groups are similar, although this is not statistically significant, this difference between older and 65 and younger. You can see in the Pfizer data, both age groups perform very well, with actually over 75 at 100%. What about the AstraZeneca and Oxford? In the beginning, I thought this was going to be the leader of the pack, but they were stymied by the fact that they found a very strange result with a low dose and a standard dose having a higher efficacy than a standard dose followed by a standard dose, with an overall efficacy of 70%. Nevertheless, because it's cheaper, you can store it in a fridge, it's probably going to be the dominant vaccine in the rest of the world. And the UK and India has already approved it. FDA in the US is stalling on it. Johnson & Johnson, very promising, but phase 1, phase 2 data presented so far, 90% neutralizing antibodies by day 29, 100% by 2 months, at least lasting for 3 months, and more to follow with phase 3 data expected within a month. Novavax, again, a little bit on the trails of J&J, different kind of vaccine, an assemblage or corsage of spike proteins presented in nanoparticles. Chinese vaccines have been disappointing, but they've really ramped up production. And again, they will contribute to immunizing the rest of the world. The Russian vaccine is a traditional adenovirus vector vaccine called Sputnik 5, notorious for administering it into people without any clinical trial data. But now they have the clinical trial data after the fact. It's about 90% effective. So what about some of the new issues in vaccinology? Well, people have heard about these severe allergies. The MMWR actually presented a very nice report on giving us some idea of incidence. So they looked at the adverse effects that people reported to in the VAERS system between December 14th and 23rd. At that point, we had administered almost 2 million doses in the US of the Pfizer vaccine. There were 21 cases of anaphylaxis, which is about 1 in 100,000 risk. So very, very rare. 71% occurred within 15 minutes. Most of the others occurred within 30 minutes or so. 90%, interestingly, in women. Again, as I mentioned, it's thought that these nanoparticles, that fatty bubble that encases that message, that messenger RNA, is responsible for these severe allergic reactions, which probably won't be seen in the adenovirus vector vaccines. The other big news, of course, people have heard about is these COVID-19 variants. The UK, of course, was first on the map for this, where it really exploded in the UK and was thought to be at least 60% more transmissible and really exploded in the southern part of England and then took over the rest of the UK. Luckily, we have some recent data showing that the vaccines are still effective against that variant. And that's not a surprise. Vaccines will probably be effective for many years before any appreciable variant becomes a strain and becomes so far into the vaccines and the antibodies elicited by them. The most recent kid on the block, joining the UK variant, the South Africa variant, and the Brazilian variant, is our own California variant. It has the footprints of the UK variant. It jumped in incidence or prevalence actually from 5% in early December to around 25% by late December, early January, and responsible for several outbreaks in the state, including a very famous outbreak in Santa Clara County in San Jose Kaiser Emergency Department, where someone wore an inflatable costume, was asymptomatic COVID positive, and 70 healthcare workers got infected and one died. That was linked to this COVID-19 California variant. What about the next section I will speak on is really about suspicions. And you can't blame people for being very anxious and suspicious of all of these efforts. Even the name Operation Warp Speed evokes an acceleration of science, which wasn't necessarily the case. And of course, it really spoke to the bureaucracy and the red tape that was cut down to enable these vaccines to get to people on time. But when you look at the racial composition of the vaccine trials, you can see that Blacks are not very well represented, considering that these are international studies. In the Pfizer phase 3, 9% Black. Moderna phase 3, 10% Black, but 4% in phase 1 to 2. And then they reacted to a lot of pressure from the scientific community and really did a lot of inroads to try and get that number up to 10%. AstraZeneca, based in the UK, very poor representation, African Americans and Afro-Caribbeans and Europeans, with only 4% Black, 1% in phase 1 to 2. Possible solutions to this, we had mentioned before, is specific outreach, money, diversifying staff and workforce, of course, and journals who publish these studies to really ensure radical transparency. And as Dr. Albert pointed out, we had depicted this to represent the challenges in diagnostics and how the section and limitations of COVID-19 clinical trials insofar as it relates to minority populations. And there's several, but the main point is that minority providers and scientists are not represented in the communities in which they are trying to serve. So I think as we continue to diversify our workforce, hopefully these issues will become better. So that gets us to trust. And the good news is that from the sequential data opinion polls, it seems that African Americans, the proportion of those not willing to get the vaccine has declined from around 49% in September to about 35% in December, but still a lot of progress still needs to be done. And why is that so? Dr. Albert mentioned some of these causes, but they also relate to testing. And when I think about vaccines, I don't only think about the opinions, I worry about what's going to happen with distribution, but I'm glad that Dr. Nunez is on the case. So we'll probably encounter issues regarding accessibility. She talked about using mobile vans, et cetera, and big sites, which I think will be a great idea. Mistrust, of course, outreach to the communities, financial issues like getting to a site and transportation, and the digital divide, since many of these appointments are made by getting on an app, very similar to the early stories in diagnostic disparities. So what are some possible solutions? Well, I think first of all, we have to acknowledge very clearly why, this mistrust and the historical legacy, Tuskegee, Henrietta Lacks, and HPV cells, et cetera. We have to acknowledge this and validate people's feelings of suspicion. We have to educate not just the patients and the community, but also ourselves and our colleagues, and particularly around dispelling myths. I mentioned diversifying the workforce and engaging with communities using very creative measures, as some of the innovation winners will discuss, church outreach, et cetera, barbershops. These have all been invoked as potential engagement with the community for vaccination. And as Dr. Lisa Cooper said in an NPR article, the key is for them to feel a sense of empowerment and control over their own health and their own decisions. So to close, I'm hoping this will play, but let's see here. This is another way to get to the population, which is using TikTok. So people try to get me on TikTok before. I still feel a little bit shy. So I'm glad that Dr. Krista Marie was able to do it. But again, very creative ways of getting to the communities that we worry about. So in summary, I really worry about not only the disrepresented or the underrepresentation of minority populations in trials, but some issues around acceptability, hesitancy, and ultimately distribution. Thanks a lot for your attention.
Thank you, Dr. Chin Hong. Really appreciate that stellar update on vaccines and the issues involved in vaccine hesitancy and especially the science related to vaccines. We're thrilled to have our next speaker be Dapo Ilyumade. Dr. Ilyumade, take it over.
Okay, thank you for that kind introduction. It is my pleasure to be speaking with you today. Let me just share my screen. Okay. So it's a pleasure to present the Youth Tackling COVID-19 initiative, which is a collaborative effort on the part of the University of Miami Miller School of Medicine and the Herbert Wertheim College of Medicine at FIU. I'm joined today by some outstanding students from both institutions who you will be hearing more from later and who will be helping me present this project. So our project aims to slow the COVID-19 pandemic by addressing the infodemic. And so through educating and mobilizing Black and Latinx youth via a series of webinars, we plan to engage the greater community utilizing targeted social media campaigns to achieve this goal. The two ABC faculty advisors on this project are myself and Dr. Cheryl Holder, who's our current president of the Florida State Medical Association, as well as Dean of Diversity and Inclusion at the FIU College of Medicine. So over the past 9 months, we have all witnessed the carnage that misinformation can produce. And with that, existing disparities in healthcare have worsened. To focus a bit on the racial disparities, we see here that despite representing only approximately 1.5 times the number of cases compared to their white counterparts, Black and Latino people represent nearly 3 times the number of deaths and 4 times the number of hospitalizations. Here, another way to represent the data. Here we see that Black people alone account for 16% of COVID-19 deaths, where race is known. So one thing that our group recognized and that led to the development of our project is that COVID-19 is not only a pandemic, but also an infodemic. And despite 23 million cases and 400,000 deaths in the United States, public health data has still been varied depending on which source you choose to read. So whether it's the CDC, the WHO, your state's Department of Health, or local health systems and health professionals, the information is pretty scattered and you receive bits and pieces from here and there. And this has led to varied perceptions amongst the populace. And furthermore, stay-at-home orders have led to people spending more time on social media. More time on social media has led to exposure to more opinions and expressions of extreme opinions. and that has only added to the confusion. One thing that we believe health policy leaders have not clearly identified and really can take advantage of is understanding how to communicate information to the correct demographic. So amongst their contemporaries, the baby boomer generation, media consumption is vastly different from the way that Generation Z, for instance, members of Generation Z consume their information and get their news. And so studies have shown that 95% of teenagers own smartphones, 97% of adolescents utilize social media, and for the first time in history, social media has eclipsed the printed word with respect to viewership. I'm now going to pass the mic to Eric Helm, who's one of our astounding med students at IU.
Thank you so much, Dr. Liamade, and thank you so much to the ABC. I'm excited to be here today. So one of the things that this project really focuses on is misinformation, and then how to combat misinformation in a way that is culturally relevant to the populations that we serve. So we want to start with a framework of how we view misinformation, because it's important to understand that theory before we try to apply any kind of intervention to correct it. So misinformation serves a lot of different purposes. So here we have there was a fake documentary that circulated on social media called Plandemic. An anti-vaccination activist known as Dr. Judy Mikovits. She used to be a scientist at the NIH, and now she gets paid very large sums of money to do anti-vaccination speaking series. And she was featured in this documentary that was riddled with many misinformation or misleading claims about the virus, and it was viewed more than 8 million times on social media before Facebook, YouTube, and Twitter were able to take it down. So on the one hand, this is an example of when the profit to be made with misinformation. Then Dr. Stella Emanuel, many of you may have seen her, and her colleagues, many of whom were also physicians, in front of the Supreme Court, giving a talk on how there's hydroxychloroquine as the cure to the virus. You don't need to wear a face mask. And with Dr. Stella Emanuel, a lot of this is rooted in deeply held religious beliefs for her. There's no problem here with education or intelligence. She just genuinely holds these beliefs that may not necessarily be true. And in speaking with some of my colleagues, I learned that she's still making new videos that are making the rounds on WhatsApp among Haitian and Nigerian populations, for example, because she does make a religious connection that public health officials may be missing. So what is it that we as public health officials are missing in a link to be able to communicate with all populations? And then finally, we of course have former President Donald Trump. And while it goes without saying, it always necessitates saying that people will always use information, have always and will always use misinformation to consolidate their power, as we saw so dangerously play out with the terrorist attack on our Capitol several weeks ago. So information overload just impairs personal decision making. So this is a really busy slide because it's a really busy time. So imagine that you're a mom, and as many people on this call may be, mom or dad, any kind of guardian, and you're trying to decide whether or not to send your kid back to school or keep them online. And on the one hand, your mom is telling you that, oh, your child has asthma. If he gets the coronavirus, he's going to die. While your friend who's a nurse is saying it's fine, the coronavirus is no big deal. CNN says one thing, Fox says another. Your local public health department says different from your state public health department. Meanwhile, for example, there's a mental health crisis going on among youth in the country right now. So maybe now your child for the first time has to take antidepressants because they are isolated at home and anxious about the future. So there's just so much information coming at you. It's a little bit like that common example used in medical school of drinking out of a fire hose. In medical school, right, you are given an overwhelming sum of information, but then you were given several years of training of how to consolidate that information, filter out what's extraneous, and come up with a care plan that is actually useful for the unique patient sitting in front of you together as a partnership, which is very much what we to do with our project. So for example, when you look on the internet, 40% of the top, one study showed that 40% of top research results were from unreputable sources. Another one found that 50% of all misinformation related to the pandemic originated on social media. Finally, both the World Health Organization and the United Nations have both put out calls for action plans to manage the infodemic that engage and listen to their communities. So as you'll learn in a few moments, our project very much is about youth empowerment and youth creating their own action plans to manage misinformation. And we really, and we're excited to tell you about it. So over to Ayi.
Hi, everyone. My name is Ayi. I'm a third year at University of Miami. So thank you, Eric, for giving all of that background information on misinformation and how it can be dangerous. So our project, we're trying to figure out what we can do. So what our plan is to deploy target evidence-based information to youth using like impactful sources. And we're going to utilize social media to create real-time culturally relevant health information like Dr. Hong Chin did right before us. We can't take away information overload, like that's not possible with the internet, but we can empower people to learn how to manage that information and to filter it down to something that they can work with. So Youth Tackling CODE's mission is to slow the spread of SARS-CoV-2 through the development of a novel public health education model that empowers Black and Latinx youth in Miami-Dade County. So we have a series of goals. Number one is to educate youth about COVID, because when you have that education, it becomes a lot less scary and you can start to manage the information that's being thrown at you. We want to teach youth to critically appraise the health information that they're getting. So let's say they see one of those reputable sources, they will be able to realize that it is unreputable and to look somewhere else. We want to mentor youth in STEAM careers, science, technology, engineering, arts, and math careers, which we will be doing through our interdisciplinary team. And we want to discuss the prominent public health policies overseeing the COVID-19 pandemic. More on our goals. We want to train youth in artistic design and principles. Again, that will be part of our multiple disciplinary team. We want to incentivize participants to create their culturally relevant, medically accurate, and social media content, and we'll be doing so through cash payments. And we want to foster the leadership and decision-making power of Black and Latinx youth by challenging some of them to create their own capstone project, which I'll be explaining more about in just a moment. One of the things that's really important to us is helping to put money back into Black communities. As was stated before, there has been a lot of economic impact to Black and Latinx communities. So in our project, along with incentivizing them to do the social media challenges, we want to help them put money back into their community. So we'll be giving them cash payments so they can support their family. And we'll also be providing a list of locally owned Black businesses where they can be encouraged to spend their money.
Thank you, Ayi, for establishing our goals for the viewers. I'm Angelique, and I'll be discussing more of our methods and our team. So first, we wanted to form a diverse, sustainable team to facilitate our goals. We have medical students at Florida International University and University of Miami's, their Student National Medical Association chapters, which have partnered to establish a permanent link to continue future iterations of this program. We'll also have graduate public health students that will build upon the GROW grant program for their community practicums at their respective schools. We have the Neighborhood Health Program, which is FIU's signature community health program. It partners in medical, nursing, and social work students that work with individual households throughout their education. This provides a strong interdisciplinary foundation of students to lead webinar sessions. And we also have the Create and Amplify group. It's a collective of graphic designers and landscape architects that are dedicated to uplifting Black voices. They have offered to mentor participants in this program, which will greatly help to facilitate some of our goals, which we'll talk about later. In regards to our community partners, we have participants that our community partners will help to facilitate some of our participants. We have UM's Barbershop Docs. It's an outreach initiative that's been well established. We have the 100 Black Men of America's Miami chapter. We have 24 churches that Dr. Cheryl Holder, the president of the Florida State Medical Association and our faculty member, has currently partnered with as a part of a grant to increase COVID-19 testing. We have 13 other identified partners, as well as collaborations with National Medical Association affiliates, including the Florida State Medical Association and the James Wilson Bridges Foundation. And they have pledged $1,500 to the sustainability of the YTC program. So that was our community partners and our team. But you'll ask, how will we do it? As we've previously said, it's youth tackling COVID. We'll have the youth as ambassadors. The high school students in Miami-Dade will be taught the communication, design, and source appraisal skills, which we'll review later. And we also have the participants put their skills to the test by completing these social media challenges that we discussed. Our key parts of our program is the webinars. This is really how we're going to do it. We'll have a series of 6 webinars, one held each month, developed by our team. This team includes the health professional students we discussed, the graphic designers, landscape architects, and political science students. The participants will turn in that content, that relevant data, and a statement on the sources they're going to use and why. This format can be replicated to address other critical health initiatives, things like hypertension, diabetes, vaccination, and systemic racism. The information our students will learn does not have to end here with COVID. So let's discuss some of these webinar topics. This is the meat of our program. Our students will learn topics on misinformation on social media and COVID-19, similar to things we've already discussed earlier in our presentation. They'll learn about personal protective equipment, epidemiology, and vulnerability. We'll have design perspectives on public health communication, civic engagement as a social determinant of health, and vaccine development and community involvement in research. You may ask, how will these topics be helpful for children? How is this going to stop COVID? Well, addressing the PPE and vulnerability can address fears about the virus and fears of being thought of as weak for wearing a mask, which you have seen often come up on social media. Design perspectives on public health drives home the interdisciplinary nature of our program. We'll discuss the built environment of streets, parks, public transit, things like apartment complex and how much greenery is around, and how this contributes to your health in general, and particularly how this built environment has impacted COVID-19. This really links into health disparities, things that were addressed in public health that really are widening this gap in the morbidity, mortality rates we've seen with COVID-19 in the Black and Latinx community. Civic engagement is very key right now. America right now has been very polarized, and we don't want to shy away from the conversations. They're very important. We want to learn from them and engage the youth in discussions on how politics has impacted their health and how they can take an impact, a personal approach into this. We want to come together with the youth and show them that we are a team working together for the betterment of our country. And lastly, the vaccine development and community involvement. The parents are going to be the ones deciding vaccine and health decisions for the youth right now. And they need to know these things, so help educate their parents to help trickle that information up, as a lot of this information right now is being spread on social media and the youth are directly engaged in that, as we discussed earlier. We also understand that there's been a lot of history in abuse in medicine, a lot of misinformation, and a lot of mistrust in our community. And we want to address that and have discussions on it with our youth. We don't want our webinars to be ahistorical. We want to give our participants context as to why their families and friends hold these specific opinions about scientific research. And we want to empower them with the tools to make decisions for themselves and to teach other people as well. Thank you.
Thanks, Angelique. That was great. I think that it's really important to hone in on this discussion about safety. Because we're talking about youth who are a vulnerable population, it's important to make those considerations. So in the spirit of COVID-19, for the protection of our participants, our researchers, and our community partners, all of our webinars will be virtual. And because our project relies mostly on social media challenges and so forth, we will be making sure that we equip our participants with tips about security or safe social media practices regarding security, safety, stranger danger. Another thing that's important for us to mention is that we know COVID-19 discussions about that can be very distressing to youth, considering that this pandemic has been happening for so long and it's been having widespread effects personally in our families and our communities. So making sure that we open up a safe space for our participants to discuss that and also provide them for resources to go ahead and have further discussions if needed about that. Now the impact. We're trying to do something novel here. We're tapping into something that's not typically tapped in as far as going into challenging or trying to combat COVID-19. And we really have high expectations. Our minimum reach that we have estimated and calculated is mostly based off of the social media reach, but also based off of the fact that our youth participants are going to be communicating this information that they learn in webinars with their family members. So if we approximate that about 3 people per Miami-Dade County household, we're expecting that within this the realm of our program, we're expecting at least 16,000 people. In addition, we know that everything that happens on social media and that's published on the internet lasts forever. So really, the extent of this impact can be immeasurable. We know that this project is new and novel and can be applied to a lot of different public health initiatives, but we recognize that it's scalable and it's reproducible, and we're excited to see what's going to happen next. So how are we going to be measuring that impact? What is the data we're going to be collecting? We are going to ask that our participants, once they complete their social media challenges, send us screenshots of what they've produced and put out into the world. And then we'll be able to track their posts, views, likes, and reposts, and other measurements of social media engagement. We will also be asking them to complete surveys, a survey at the beginning of the program, a survey at the beginning of the end of the program, and then also a pre and post survey for each individual webinar that we will be hosting. The idea is through these surveys, we'll be able to track their knowledge of COVID-19, their knowledge about public health in general, and how social media has impacted their knowledge of these things, as well as their behavioral practices. And then comparing the pre-information to the post-information, we'll be able to have some numbers that quantify the impact of our program on their knowledge and on their behaviors. And then all of this data will be analyzed through the help of biostatisticians at FIU. And I know this was hinted at before, but we are planning to really put more emphasis on leadership within our participants by inviting them to apply for a capstone project and use some of the funds that we'll be getting for the grant to create their own project. We recognize that the youth are members of the community, and they know best about what are the best strategies to combat COVID-19 within their community. So this is about empowering them to take hold of that and be youth public health ambassadors and run with that. So hopefully you've enjoyed our discussion about youth tackling COVID-19 and what we are planning to do. What's really exciting about this is we're tackling a unique aspect of the pandemic, the infodemic, and we're empowering youth to go ahead and grab it by the bullhorns and keep it going and see where they'll be able to take it. So we're excited about this. A big thank you to ABC for this grant and for their support. We're really excited to see where this is going to go. And we know that we wouldn't have been able to do this without your support. So we are definitely very grateful. And we know there are a lot of healthcare workers and physicians on the call. So we'd like to thank you for your continued support and work throughout this pandemic, and work forever. And then we just like to highlight that this, again, is an interdisciplinary effort that's between medical students, public health professionals, graphic designers, librarians, just a ton of people throughout South Florida. And we would like to highlight that this is going to be a community project for the community by the community. So thank you.
Thank you, Dapa, Ai, Eric, Angelique, and Kelsey for that wonderful presentation. We're really looking forward to seeing the results, and we're especially thrilled about the focus on youth. Our next speaker is Dr. Ilana Morris.
So the title of our project is the Georgia COVID Consortium. It's an academic clinical community partnership to study the impact of COVID-19 across Georgia communities. So as we've heard throughout the pandemic, of course, deaths and cases have disproportionately affected African Americans in most states, and Georgia is no exception to that rule, unfortunately. There are some unique aspects, I think, of the pandemic in our state. As many of you recall, Georgia was the first state to reopen. Many states, the entire country, in fact, sort of sheltered in place when the pandemic first started. And I think because of political as well as financial pressures, our governor decided to reopen our state very early on in the pandemic, long before any of the metrics that the U.S. task force had put in place as sort of quality metrics that states should follow related to cases in terms of deciding when it was safe to reopen. And so because of that, when we were looking to submit this grant last summer, when we looked at sort of the way that cases were rising in our state, we were really seeing somewhat of a lull and then really a boom in terms of cases because of that. There were some other interesting aspects to the political aspect of what was going on in our state. Again, there was a sort of a well-politicized lawsuit that was brought on from our governor against the mayor of Atlanta, Keisha Lance Bottoms, because there was never a mask mandate that was put in place by our governor. Many of the cities in the state of Georgia, including Atlanta, instituted their own mask mandates in order to try to keep cases low and to protect their citizens. Well, our governor decided to sue Mayor Keisha Lance Bottoms, and this really brought about a lot of national attention, and many of the healthcare workers, including those at Emory, actually issued letters really asking our governor to reconsider that stance because it really contributed to us really never getting control of the pandemic in our state. There were some other unique aspects of the early part of the pandemic in Georgia that really caused us to want to look at the way that things were going in our state. Of course, Georgia is a very diverse state. In fact, about 40% of the population is minority, about 30% are African American, about 10% are Latinx. And there was a publication that came out from the CDC last May looking at hospitalizations that had occurred with COVID-19 in March of 2020. So again, very early on in the pandemic, that showed that 83% of the hospitalizations that occurred in March of 2020, 83% were in African Americans. So again, very early on in the pandemic, there were some suggestions that what was going on was really disproportionately affecting African Americans in a very severe way. When we started to look at the data with some collaborators in the School of Public Health here at Emory, we started to see trends that really mirrored the data that was coming out of the CDC. So when we looked at cases per 100,000 in the state of Georgia, we could see that Hispanics or Latinx communities accounted for the highest number of cases per 100,000, with African Americans not far behind and whites accounting for the lowest number of cases. However, when we looked at COVID-19 deaths per 100,000, again, African Americans were significantly disproportionately affected. So some very, very scary statistics that we were noticing last summer. Again, some very common cardiovascular risk factors were noted to increase the risk for severe illness from COVID-19. Things like hypertension, obesity, type 2 diabetes, that again, early on in the pandemic were not necessarily on our radar as conditions that were going to be associated with severe illness from COVID-19. Of course, these conditions are very common in the southeastern part of the United States, are very common in Georgia. 35% of Georgians have hypertension, about a third are obese, over 10% have type 2 diabetes, 10% have serious heart conditions like prior MI and stroke or heart failure. Of course, when you look across race ethnic lines, those numbers or that prevalence increases even more. And so when we look back to some early publications from members of the ABC in terms of thinking about how to tackle these disparities related to severe illness from COVID-19, there were some suggestions made from the ABC about how different community members and or academic partners could think about what to do. One sort of solution was for us to partner with community members, of course, but to also focus on supporting education, to make sure that we expanded and easily access testing for patients, and then also to make sure that policy initiatives really address disparities both at the local as well as the federal level. So as we were writing this grant, we really wanted to make sure that we addressed these aspects in terms of what we were suggesting that we were going to do. So when we thought about how to put this consortium together, the first aspect was to partner with community members. So Emory, certainly Emory Healthcare, under the umbrella that includes Grady Health System. Grady is sort of unique in that it's the largest safety net hospital in Atlanta, but it actually includes faculty members from Emory University as well as Morehouse School of Medicine. In addition to that, we were already collaborating at Emory with the Georgia Department of Public Health. We were utilizing data on testing from the Georgia Department of Public Health to track persons under investigation for COVID-19 to really look at what was going on in our patient service area. And then we also decided to partner with Piedmont Healthcare as well as Wellstar Health System. So we thought this was somewhat of a unique aspect of things. We were almost sort of partnering with the enemy, if you will. I think all of us are sort of well aware that the way that modern day medicine works is we're all trying to sort of carve out our own unique patient service areas within our own healthcare systems to make sure that our healthcare systems can survive. However, it became clear within the pandemic that our healthcare systems really needed to pull together to make sure that our patients were well taken care of and that we were really addressing disparities. And so because there were members of the ABC within Piedmont Healthcare as well as within Wellstar Health System, I reached out to those ABC members early on in the pandemic and said, hey, would you be willing to be part of this Georgia COVID consortium so that we could really reach across our healthcare systems and make the point that this was something that was important to do beyond our healthcare systems to make sure that we were addressing disparities and sort of tackling this really large problem within the pandemic. And so when you look across the patient service areas for these 4 health systems, really, even though Grady is, again, its own entity sort of under the umbrella of Emory Healthcare, we actually provide care to almost half of the residents in the state of Georgia. And so we thought that collecting patient level data from these 4 health systems would really allow us to get a sense of not only the amount of chronic health and disease that exists within the patients who get their chronic care within our health systems, but we would also be able to link that data with data from the Georgia Department of Public Health to look at data on testing, as well as look at what was going on within our own healthcare systems in terms of who was getting hospitalized and what the outcomes were for patients across those healthcare systems. The other unique aspect in particular of including Grady in our outcomes is that Grady provides the most uncompensated indigent and charity care of really any hospital in the state and really has more care to indigent or charity care patients than any hospital. Again, if you look at these numbers, about over 30% of the care that Grady provides is to uninsured patients, and this is well beyond any other healthcare system in the state. So our first aim is to characterize the care continuum of the COVID-19 pandemic in Georgia, to comprehensively integrate community testing data with patient level data to determine how factors including race, ethnicity, social determinants of health, and the availability of medical services affect clinical outcomes. So again, we already had access to data from the Georgia Department of Public Health on COVID-19 tests. And that data included actually patient name, date of birth, residential address, both the type and the number of tests that each patient received, as well as the test result. And so with access to that testing information, we could then go back and take that information and integrate it with patient level data from each of our healthcare systems by pulling data from each of those systems' clinical data warehouses. And so we put together a data dictionary that we would use to pull data from each of these clinical data warehouses, including data on sociodemographics like age, gender, race, ethnicity, residential address, type of insurance, of course, data on clinical history like Charleston Comorbidity Index, hypertension, diabetes, HIV, usual laboratory data, including metabolic panel, as well as inflammatory markers that are associated with evidence of more severe COVID-19 infection like CRP, ferritin, D-dimer, procalcitonin, the actual SARS-CoV-2 test that we administer in the hospital and the results in the number of those tests, the acuity of illness, including admissions to ICU, evidence of respiratory insufficiency, requirements for mechanical ventilation, ECMO, dialysis, cardiogenic shock, length of stay, death, discharge to home, and rehab. Because we would have information on residential address, both at the level of testing, as well as when patients come into the hospital, we would be able to calculate different scores related to social vulnerability, neighborhood concentrated disadvantage that we could use as well to look at patients' neighborhood disadvantage as a marker of who comes into the hospital and who has more severe outcomes. So again, if we think about partnering with our community members, this is what our team looks like. Another aspect of how we were going to take this information and deliver it back to our patients and our community members, it was very important that we deliver this information with a team that reflected the disadvantaged community that seemed to be suffering the most. So we wanted to make sure that our investigative team was reflective of the community that we were trying to reach. And so certainly our Emory team, our Grady team, our Piedmont team, and our Wellstar team members, again, are members of ABC and our cardiologists, Emory emergency medicine physicians, who are from underrepresented backgrounds, and again, hopefully would be members of the community that our patients hopefully would trust to perhaps get rid of some of the barriers related to mistrust, so that when we focused on not only who was being most affected, but perhaps when we got to the place where we are now related to treatments that were available, as well as a vaccine, that when we were delivering this information and talking to marginalized communities, that perhaps the information would be being delivered by clinicians and scientists that our patients would feel akin to. In terms of our second aim, we wanted to create or really enhance a public-facing dashboard for community organizations to enhance community education and public health efforts on testing that were appropriately targeted towards the most vulnerable communities. This is actually an opinion piece that was written by Monique Smith, again, who's an emergency room physician at Grady within Emory. And Monique wrote this piece on COVID-19 testing deserts that really hindered fighting the pandemic. Georgia is a place, and Atlanta is a place where most people drive. And so what we saw early on in the pandemic, and still to this day, is that many of our testing sites are drive-through testing sites. Well, of course, if you don't have a car, if you ride the bus, that really hinders your ability to get and access a test. And so many of us, and Monique has been writing about this since very early on in the pandemic, and been working with our administration at Emory to say that this really disadvantages our patients who come from socioeconomically disadvantaged backgrounds. We want to make sure that we don't disadvantage people who don't have a car, people who ride the bus, and we want to make sure that, for example, we have mobile campaigns, that we take tests to communities who may not be able to drive to access testing in order to fight the pandemic. This is a dashboard that Shivani Patel, who's one of my collaborators in the Rollins School of Public Health at Emory, implemented very early on in the pandemic. And this was really implemented to track COVID-19 disparities by race and ethnicity. You can actually go to this website right now. It's covid19.emory.edu. You can actually find your state, and you can look at both the number of cases and deaths in your state, not only as a function of state and county, but you can track by race, ethnicity. And so you can look at the number of deaths in your county or in your state as a function of the percentage African Americans in your county. And what we'd like to do with the data from this grant is to supplement this website by, again, using this to perhaps, again, integrate patient level data from these different health systems to, again, integrate data on the various comorbidities, but to also perhaps also add data on testing and perhaps implement which patients are getting treatments as well as vaccines now that that's available. So again, our second aim was to enhance or create a public-facing dashboard for community organizations to ensure that community education and public health efforts on testing are appropriately targeted towards the most vulnerable communities. At Emory, very early on in the pandemic, we had created a collaborative community outreach and health disparity steering committee that was convened to address the disproportionate burden of COVID-19 on Black, Indigenous, and people of color communities in our patient service area. And what we had been doing was integrating data from the Department of Public Health with patients who came into our health system that were considered patients under investigation. And we were using that data actively on a daily basis to identify what we were calling, again, hotspots. So areas where we were seeing lots of patients and lots of positive tests, but also blind spots. So areas where we were perhaps seeing patients who were coming in from certain neighborhoods with lots of severe disease, but perhaps weren't getting as many tests at the level of DPH. And we were sort of steering our mobile testing into those neighborhoods, but also working with our county departments of public health, primarily Fulton and DeKalb, to make sure that we were targeting mobile COVID testing into those communities to drive education, prevention, as well as other intervention efforts. And so the goal for AIM-2 within this grant was to really expand those efforts to include these other Georgia health systems. So now that we have this partnership with both Grady, Piedmont, and Wellstar, we can really expand those efforts, expand mobile testing, use this integrated data around testing, as well as this data on who's getting hospitalized and who's dying based on the results from AIM-1. And that data will be further used to guide not only this mobile engagement campaign, but again, now that we're in an era of vaccination, to also perhaps guide vaccination efforts in these vulnerable communities. So again, when we look back to this really elegant paper that came out from our members at the ABC, we had these goals of partnering with our community members and using some of the data from this grant to support education, expand testing, and now that we're in this era, hopefully expand vaccination and treatment, and really guide policy to address disparities, again, both at the local and the federal level. Of course, when we wrote this grant, we were hoping that by the time we got the money and by the time we were doing this analysis, that COVID-19 would have gone away. Unfortunately, that's not true for any state, including our own. We are very much in a surge, just like I think many other states. In fact, as of last week, we were ranked 4th nationally in the number of COVID-19 hospitalizations. I was actually on inpatient service last week, and I think the data from our state was that over a third of the hospitalizations statewide were related to COVID. So we are very much still in the thick of things, and the data that we collect, hopefully as part of this grant, will still be very relevant. So I'd just like to acknowledge the Association of Black Cardiologists for the funding and the ability to do this grant, as well as the collaborators that will be part of this effort. And this is my contact information, and I'm excited for the opportunity.
Thank you, Alana, for presenting such a comprehensive project. Now, our next speaker will be Dr. Donald Lynch Jr., who is from University of Pittsburgh, assistant professor at the University of Pittsburgh, who will be talking to us about leveraging mHealth to mitigate the impact of COVID-19. Welcome, Dr. Lynch.
Sorry, and for correction, I'm at the University of Cincinnati, but let's see.
Sorry, I apologize.
No problem. Thank you guys for the opportunity to present today. I am the last speaker within the lunch hour, so I'll keep it brief. My co-awardees have done a great job of covering really the impact of the COVID-19 pandemic on the Black community and globally, as well as locally within our communities. So the title of my talk is Leveraging mHealth to Mitigate the Impact of COVID-19 in African American Communities. I'm an assistant professor at medicine in the Division of Cardiovascular Health and Disease at the University of Cincinnati, where I am an interventional cardiologist and physician scientist. So I'll cover, objectives-wise, we'll cover a bit of background as to why we developed our project. We'll talk a bit about COVID-19 racial disparities, but these have been covered quite well. We'll discuss the role of faith-based institutions, and particularly in response to the COVID-19 pandemic and distribution of both education, awareness, and resources. We'll talk a bit about the role of communities and engagement, and briefly sort of talk about a bit of our community innovation project. COVID-19 has had an incredible impact globally and within the US. And so based upon the current data from the Hopkins COVID-19 resource, there are 97 million cases globally, with 24 million within the US, and approximately 2 million deaths globally and over 400,000 within the US. Among those with COVID-19, as Dr. Moore has highlighted, there are worse outcomes and higher rates of death seen in those with cardiovascular risk factors, including hypertension, diabetes, obesity, lung disease, and cardiovascular disease. And this really highlights the importance of making sure that we get patients that have been disconnected from the health system back into establishment of care with the primary care providers, as well as following up with their other physicians, such that these risk factors are identified and managed. The COVID-19 pandemic has, as others have highlighted, has really exacerbated the pre-existing health inequities already present within the US and predominantly among the African-American community. This has translated to a higher risk of dying due to COVID-19 for African-Americans, which some studies have quoted up to threefold the increased risk of death for African-Americans. As you know from the American Heart Association data, even if we look specifically with inpatient outcomes, 50% of the patients that require ICU admission are actually African-American. You see here in the figure to the right is that Black African-Americans amount to 142 deaths per 100,000 people by race or ethnicity, while whites only amount to 91 deaths per 100,000 people by race and ethnicity. This is, and so for our project, we're using 3 different sites. And what you can see from this figure is that the death rates are increasing predominantly within rural areas such as Statesboro, Georgia, which is one of our sites for our project, but also they continue to rise in metro areas. Faith-based institutions have had very important roles within the African American community for a number of years and, over the course of time. And compared to populations as a whole, African Americans are more likely to affiliate with a religion, attend religious services, and place religion as important in life. Overall, 87% of African Americans describe themselves as belonging to a religious group. The COVID-19 pandemic has, as I mentioned, has disproportionately affected African-American communities. And you can see in the figure to the right here, this is specifically for St. Louis, but you can see, across, a number of rates per 1,000 residents that really there's a higher proportion for African-Americans across the spectrum. Based on data from the COVID-19 racial data tracker, more than 50,000 African Americans are now dead from COVID-19. And this doesn't even account for 20,000 deaths in which race data has not been reported, highlighting one of the current gaps in resources for African American communities. So our project was largely driven by questions from patients in clinic. And so here I've listed a couple of the questions that are quite common that both myself and my staff identified. As examples, a lot of patients come in wanting to know if it's safe for them to get COVID-19 vaccine with their cardiac device, or if they have recent stents. Does their doctor recommend getting the COVID-19 vaccine with their current cardiac issues? Do you know when people over the age of 65 will be able to get the vaccines? We know that, this is a state level decision. We've recently started vaccinating those over the age of 80, but others are doing over the age of 65 with comorbidities. Will it make me totally immune to the COVID-19 virus? What are the most common side effects? And should I get the vaccine if I'm already had COVID? If you get vaccinated with a COVID test, come back positive, how long are you contagious? And if you have persistent symptoms, are you still contagious? So the objective of our project is to leverage mobile health to increase education, awareness, and prevention of COVID-19 and cardiovascular disease. As Dr. Morris highlighted, early on when we wrote these projects, we were anticipating that COVID-19 would be to a much better point of resolution, but that's not the case, as we all know. As a critical step, we're going to improve access to diagnostic testing for the African American community, and we'll also inform the community on how they can be vaccinated. So here I've shown some data from Dr. Raymond Givens at Columbia University. And what he highlights is that we know that the pharmacies are going to be a predominant site in which people will have access to vaccination. And as our first speaker noted, really you want to get as many people vaccinated as possible. But he just wanted to highlight here just where the areas of active pharmacies are, and where this will not be a resource that will be best utilized for distribution of vaccination. Unfortunately, this seems to track with areas that are higher rates of mortality. And so the areas that are in most need of vaccination are the areas that have less access to pharmacies, if this is in fact going to be the true area or true means of distribution of the COVID-19 vaccines. And so back to our project. So our communities are threefold. So we're going to be piloting our study in St. Louis, Statesboro, and Cincinnati. And what you can see here is that the communities, in terms of racial makeup, are relatively similar. But as one of the questions in the chat box here noted, is that a lot of older Americans don't necessarily have access to computers or smartphones. And what you can see here on the figure to the right is that computer access, based upon the most recent census data, is roughly about 80% in most households in all three of the communities, as well as broadband internet access is around 70% for most of the communities. And so this, if we find that we're unable to include a population of older Black Americans within our study because they don't have access, that'll be one of the major obstacles that we'll address. So our project is focused on community engagement. And so we wanted to involve community leaders or stakeholders very early in the process. And so as our first aim, we're gonna have focus groups in each of the three communities. We felt that community leaders were critically important for the success of any community engaged research. And so we're gonna work collaboratively with a panel of community participants throughout the study. And we wanna make sure that the panel is actually representative of the community at large and has a pulse of the community. And we hope to get individuals who are historically disconnected from healthcare. Our three aims for our study. So during aim one, we're gonna partner with faith-based organizations to assess preferences for COVID-19, mHealth, interventions targeting African Americans. Based upon results of that, we're going to develop an app that will conduct a pilot study during aim two to assess feasibility and the preliminary efficacy of the intervention on our intervention targets. And during the last phase of this, we'll do iterative revisions of our app, following which we'll hopefully be able to get it out to a more broad population. Sorry. And so here is how we're recruiting, people for our focus groups, and hopefully we'll be able to get them in to help us to understand how people receive information in regards to both COVID as well as cardiovascular disease and where the gaps are within available information. And as our first speaker noted, if there is misinformation out there, we want to work diligently to make sure that we address. So during aim one, as I mentioned, we'll talk about cardiovascular health and COVID-19 information and how it's accessed. and used. We'll look at the community as a whole and see if there's areas that are not been having adequate access to information. As noted in point 1, we'll discuss prevention and thoughts in regards to vaccination. There's a lot of people within our Cincinnati community that are unwilling to think about vaccination at this point, and that's for a number of reasons. We'll talk about preferences in our app or intervention, including privacy and functionality issues. And then lastly, we'll address any content needs that specifically need to be included within the app. So I want to end by acknowledging my co-investigators. So Dr. Kelly Harris is at Washington University, Dr. Mayo Gamble is at Georgia Southern University, and Dr. Raymond Givens at Columbia University. I want to thank you for the opportunity to be a part of this important seminar.
Thank you, Dr. Lynch from the University of Cincinnati for presenting your novel project to us. We are at the top of the hour, and what we have been doing as panelists is answering your questions in the chat. We hope that we have gotten to most of the questions at this point. So I think that the better part of Valo here is to move straight to our closing. This webinar, Generating Heartfelt Horizons, COVID-19 Myths and Realities, hopefully covered several things, not hopefully, but covered several things. The first is it covered the key scientific facts related to the COVID-19 vaccine and presented data about vaccine uptake in various communities and a federal plan for a vaccine rolling out. You also heard 3 novel presentations that focus around a cycle of COVID-19 care and prevention and education, focusing on youth, importantly, who serve as seeds for adults in their communities on social media, focusing on a community, large hospital systems collaboration, and then also faith-based project, as well as how we utilize technology in our communities. So I want to thank you for joining us. I would like to thank the following individuals for making this webinar possible. First, a heartfelt thank you to our speakers, Dr. Marcella Nunes-Smith, Peter Chin Hong, Alana Morris, Dapa Ilumade, and Donald Lynch. Ms. Tiara Dillingberg, who is the staff lead for this webinar and helped organize this webinar. Ms. Cassandra McCullough, our CEO, Dr. Elizabeth O'Feely, our ABC board chair, and our COVID task force members, Dr. Narissa Hayes, Dr. Peter Chin Hung, Dr. Kevin Alexander, and Dr. Alana Morris. I want to close with this penultimate slide. Again, this webinar is dedicated to Dr. Julian Haywood, 1927 to 2020. We are forever indebted and dedicated to your efforts, not only for the ABC, but for medicine as a whole. And this last slide, again, presents a collage of trusted physicians taking the COVID-19 vaccine. One of the themes that we heard for reaching and stemming the tide of mistrust is having trusted individuals who the community and our patients recognize as persons who they can believe in what they say. Hence, the ABC is committed to putting forward any data and mitigating the spread of COVID-19 through encouraging vaccinations. All of our lives depend on each other's actions. Thank you so much for joining us for this webinar today, and it will be available on the ABC website at abcardio.org.